Welcome everyone to this National Health Executive webinar brought to you in association with Brother UK. I'm Matt Roberts, I'm the editorial lead for National Health Executive, and today I'll be acting as your host and moderator throughout the event. I'll be keeping an eye out during the today's proceedings as well for questions from the audience. We have a live Q&A functionality. You'll see this on a panel to the side of your screen currently. I'll be keeping an eye out throughout, and we'll be putting these sort of questions to Greg and Richard throughout the show. So if there's things you hear that you want to hear a little bit more or ask a little bit more about, by all means, keep an eye out and put your questions in there. Today's subject matter is all around technology. The words technology, digital transformation, digital innovation, they're words we hear very often in our NHS, and they're words that when I think about them, I'm quite guilty at times of thinking large-scale projects, whole organisation-based projects. I mean, if we stop and think for a second ourselves, it's probably the images that come to mind. But our health service has great opportunities for small, quick victories as well, little efficiencies. Technology in this modern age is our superpower. It's how we can address so many different challenges. And that's one of the things we really want to focus in on today, how we can bring in technology in ways that they may save a couple of seconds for a colleague on a certain task, but over the course of a day, over the course of a shift, a week, or even among their team, those are huge wins that we can get back as a health service, huge ways technology can support. And ultimately, it gives those healthcare professionals, yourselves, ourselves, and our colleagues, the opportunity to do the reason that we're all involved in healthcare in the first place, to care for patients. I'm luckily not alone today to talk about tech, health, and all these sort of marginal gains, shall we call them. I'm delighted to be joined by Richard Stubbs, who is Chief Executive Officer at Yorkshire and Humber Academic Health Sciences Network, and who is the AHSN lead for NHS Research, as well as being joined by Greg Miller, who is the General Sales Manager for Brother UK. Delighted to be joined by both of them, and I suppose we should probably introduce them to the stage and get straight on with the real reason we're here, to pick their brains, not my own. Lovely to see both of your faces today, gentlemen. I hope you're doing well.
Hi, Matt.
Hi, Matt.
Brilliant. And I suppose we'll dive straight into the first of sort of three topic areas that we're covering today. So we're talking around technology, and as I mentioned in the introduction, about how we can use it to free up time for healthcare staff through sort of a range of different ways. We see the likes of automation, we see the likes of moving towards paperless systems, interconnecting different services, and these are all significant benefits to the health service. And I guess we'll go first across to yourself, Richard, to ask from your point of view, and I'll warn you now, it's a very difficult question. We don't like to start off with focused ones. From your experience with the HSN, what are the biggest sort of benefits we can get with technology? Is it this sort of time saving? Is this really one of the key areas we can look to focus in on?
Matt, thanks. And it's a great question. It's a great question to start off with, and it's lovely to be here. I think before thinking about the biggest benefits, it's really worth thinking about the challenge that we face right now. And we couldn't probably be having this webinar at a more interesting time for the NHS. We're just about cresting the peak of the pandemic, dare I say it. I mean, I think all fingers are crossed and all wood is touched, but we are getting there, and the vaccination program is a huge success. And yet, as it sits within the NHS, we've just had our most challenging year since we were formed in 1948, and yet here we sit looking at the second crest, which for us is an unprecedented backlog of activity. And as we start to mobilize to think about how we're going to start to reduce that and give better access to our patients, we're sat here with a workforce which is depleted and exhausted. So when we think about the biggest benefit that technology can bring, I think we have to think about the biggest challenges as well. And for me, the challenge of our current workforce status is huge, unprecedented, and dwarfs any financial challenges that we have as an NHS to date.
Yeah.
So within that context, absolutely, we can't do what we've traditionally always done, which is to run faster and to sweat harder, and in effect, to try and use the assets we've got within our fantastic workforce to somehow reduce the waiting times that we see before us. We have to work smarter, And working smarter for me means embracing technology in a way that we've never hitherto, I think, done at that kind of scale. So technologies which allow us not just to free up clinical time and managerial time, but also allow us to actually perhaps devolve certain functions, certain day-to-day business as usual functions that to a personless setting, I think are really hugely important. But equally, technology that empowers the patient as well. I think one of the things we've seen in the pandemic is we've obviously seen, I think, what we've always known to be in existence in our society, which is the huge inequalities within certain communities. And that, I think, not to mention also the fact that from a pandemic point of view, obesity has been a leading cause of the determinant of how seriously you would be affected by COVID-19. We've seen a shift on a population level from thinking about healthcare and the NHS to thinking about health and our personalized responsibility for health. So technology which talks to that as well, I think, is hugely valuable. So freeing up time, eliminating the need for humans to do certain jobs, and empowering our population, not just our patients, to be healthier in the first place, I think are the three places where the NHS is very interested to look at what are the opportunities that technology can bring us.
Yeah, certainly. As you say, there's such a great opportunity to empower the situation, and it is such a great time to be talking about that, because we are having to look at new ways of working. So why wouldn't we look at new technologies to support us? And I suppose moving over to the technology side of that, Greg, obviously you and Brother, you have a very different view in, because you are often the one supplying the organisation, the NHS organisations, with this kind of technology. And for myself, at least initially, before we engaged on a body of work with yourselves, you were very much an organisation that were about printing, about labelling, and that in my head. But you do have quite a wide scope of understanding and interest in the healthcare industry, and in sort of thinking and having these innovative questions, aren't you? So I suppose from your point of view, from a Brother's point of view, shall we say, is that something that you're really keen to engage with, to be able to provide solutions and technologies that can do as Richard says and really help deliver?
Yeah, thanks, Matt. I think when any organisation is making a decision around procuring a new piece of technology, it's really key, and Richard's touched on this before, that you start with the problem first. You start with what it is you're trying to solve first. So often we see companies and even ourselves make decisions on technology based on some marketing, or it's quite an impressive piece of kit, and you're trying to shoehorn a solution into something that doesn't and never will answer that problem, or make that workflow smoother, or whatever it is you're working on. So I think the important thing with any organization, especially NHS, is working out where are those problems within, say, the workflow, or where are those issues, where do you need to save those elements of time to increase time in front of patients and patient care. So at Brother, our solutions in the healthcare sector, as you've touched on, they are wide ranging. It ranges from digitization of documents through scanning and archiving. So that's on that that journey to digitization, which is great. As you said, more traditionally, prescription printing, which obviously we're seeing a huge decline in, and quite rightly so. The move to EPS now, brought on even more with COVID, has actually accelerated. Now we're seeing 95% of prescriptions being delivered electronically. So, but also through to our wristband labeling solutions, and that's helping with patient identification and tracking of patients and labeling of samples. But yeah, I think from a technology manufacturer's point of view, it's really important for us to get hooked into the healthcare software providers, and make sure that it's our job to make sure that those providers ensure we're part of a positive part of that workflow, and we're not kinking it. So it's really important, I think, that the technology it all fits together as part of that solution, so it's not causing even more problems.
Yeah, absolutely. And I suppose there was a very interesting point you raised there, that we're seeing a shift in some of the technologies that are doing similar things and bringing similar solutions, but we're seeing a change in the kinds of technology they are. I suppose, Richard, from the role you had as AHSN lead for NHS Reset and a lot of the rebuilding that's come out from that and your colleagues with that, is that something you've seen as well, the shift towards this need for the likes of EPRs and these sort of more cutting edge, or I suppose more modern solutions to problems that they're the same problem, it's how we label information, how we share it?
Yeah, no, absolutely. And I think we've seen a wholesale shift. I mean, what I've seen over the last almost exactly 12 months has been a cultural shift from the NHS when it comes to its understanding of how technology can support some of our day-to-day work. And perhaps for the first time, certainly in my 20 years in the NHS, a real intent to implement these kinds of technologies at scale and pace. Very little, I think, vaccinations apart, has been invented in the last 12 months. It's been actually about a realization that some of the solutions that we need have always been there in the wings, and our fantastic innovators and industry colleagues out there who've been knocking on the door, have been knowing what they're talking about. So all those things you mentioned, Matt, in terms of solutions, the NHS is absolutely, I think, primed now to think about that. But what Greg said earlier is really important. It is about understanding the ecosystem that needs to be plugged into as if you're bringing a solution into NHS. I mean, we do see still, here is a solution in need of a problem type of conversations. We have to lead with need, and we have to, therefore, I think, know that the market, the NHS market, that is ready to adopt at scale. But certainly, I think for me, the key question we need to ask ourselves is the NHS, and what I've tried to do through leading on our reset work, and in conjunction with the Health Foundation and NHS Confederation, is to understand this really fundamental question, which is this cultural shift that we've witnessed specific to the pandemic era?
Yeah.
Or is it sustainable beyond that? And if it is sustainable, what are the conditions that have allowed us to create this burning platform that we need to make sure are maintained? I think a big part of that will be about recognizing that it's not just about the specific innovations that we needed to use in a pandemic era, but actually that was only just opening the door wider, if you like. There are now, we need to cultivate that. We need to build on that. We need to look at the other aspects of our care pathways, of our organizations, and think, well, what else can we improve and how fast can we go? And I think those are the kind of conversations with organizations like Brother, which will start to give people real insight into the opportunities that are ahead of them.
Definitely, and those are quite unique conversations we often have to health. And I suppose, Greg, you're probably in quite a nice position because of this, that you, in your role with sales within Brother as general manager of sales, you don't just cover the healthcare vertical. Is it something that's very different with healthcare compared to everywhere else, that ultimately our bottom line, our biggest concern is related to how we care for patients, the care we can deliver, whereas with other industries we'll see the likes of sort of income, cost, those sorts of concerns. They're always, in my mind, at least in my experience with health service, there seems to be a little bit of a difference in the priorities.
Yeah, certainly. I mean, obviously the end result is different for the NHS as an organisation than most corporate entities, and they are very much looking at the same things, bottom line, the affordability of a solution. But there is less, I suppose, jeopardy in what, if a machine or a solution is to fall down within a corporate entity, that's going to be very different to if the solution falls down within the NHS, and that could mean lives at risk. So it does put added pressure on you as a manufacturer, as a provider of technology, to ensure that they don't come across that, they work within that workflow that they're designed to.
Yeah, absolutely. And just before I broach it back over to Richard to follow, we'd also like to hear from our audience as well. What you'll probably see appear very shortly on your end is the first of a series of live polls that we're putting out during this webinar. By all means, if you have an answer to the question, do please engage with it, and we'll have a sort of chat round. But very much this first question is around sort of whether we've seen a change in the level of acceptance, or a level of acceptance to change, should I say. Words didn't quite want to go around the right way there, but we seem to, from what we've discussed, that seems to be the case. But very much, Richard, obviously you're in an NHS associated role, you're in an organisation that is deeply ingrained within the NHS and the HSN. Is that something you've seen in your organisation? Obviously, you're at the very top. We've heard that you want to change. Is it something you've seen from your colleagues as well?
No, it absolutely is, and I think it's as I say, it's refreshing, but also I think the first time in my 20 years in the NHS that I've seen that kind of appetite for change at such a pace. And I think it's just an example of how much of a burning platform we were sat there facing in March and April of last year, where suddenly the need to go remote on anything that could be made remote was instantaneous, and that kind of rollout was unprecedented. So absolutely, I think we have. I think there's one of the questions, I guess, in the system right now is, what is the value of remote versus face-to-face? And I think sometimes these things can become a little bit too binary. It has to be one or the other. I think we'll start talking, I think, soon about blended approaches to things. I think in the NHS we do have a tendency sometimes to tend towards polarization. It must be one or the other. When actually, when you think about virtual, for example, I think there's a classic example of it doesn't have to be all things to all people. We can absolutely have virtual consultations for those for whom it's relevant, and face-to-face for those who absolutely need it. So that more sophisticated conversation, I think, is now starting to emerge. Brilliant.
And as I'm seeing the results start to filter in from the poll, which I'm sure the team may be able to put up for our audience to see shortly as well. It very much seems that sentiment is shared across, that we're seeing 50% of voters already seeing change across the board, and many of us seeing it in either certain circumstances or in certain departments. From a sort of supplier into those organisations, that's got to be quite refreshing to hear, hasn't it, Greg, that there's people very interested to change and clearly quite willing, therefore, you'd presume, to have very open conversations about their needs and what can be delivered.
Yeah, it's providing the change is for the right reasons. Again, we've kind of talked about that already. So you just, it's great that people are more accepting to it. I think obviously the NHS is a huge organisation, so it can get bogged down in layers of decision making. Yeah. So to have processes designed around obviously a terrible situation, a crisis, but that's obviously when these type of things gather pace, isn't it? The need, it's a need now rather than a desire. So it's positive for us to see that we can have conversations around particular solutions that maybe would have taken us some time to get around the table and have those discussions of in the past.
Yeah, absolutely. And that's the word need there is a very big part of this, that we have a lot of need at the moment, but we must make sure that need isn't used to sort of brush across everything, because there's many things in our NHS that probably still require some levels of face-to-face interaction, that require a lot of sort of human element. Our NHS can't be run by robots. It's one of its greatest strengths. We're not in George Orwell's 1984, and long may we not be. But it is very much making sure we get the right balance between sort of those that can be digitized, those that should be, and those that shouldn't be. We'll stick with you, Greg, on this, but from Brother's point of view, how do you factor in, or is it very much of factoring in, I should probably ask, about making sure the solutions you deliver offer the right things and aren't just sort of whole brush, that there's that sort of level of bespoke approach to it?
Yeah, I think from our own solutions, it's very much we're creating outputs or input devices that are hanging onto a software solution within healthcare. Very rarely is the end user, the patient, receiving or using that technology. They're kind of receiving an output from it, whether that's a piece of paper, a wristband around the wrist, or a label around a sample. I think for the NHS generally, it's a massive task, because you've got every age group, and you've got, so you've got patients patients over 75, nearly half of them haven't even used the internet. So sending them to a portal or saying, oh yeah, join us on this, video consultation, that's not going to work. So you have to have, as Richard mentioned, that kind of blended approach again. But technology should be hassle-free. So we've always taken great pride in our robustness, our compatibility across those software providers in healthcare, and trying to minimize those intervention of the products, because if the people using those products don't have to intervene with them, then that's giving them, again, those small increments of benefits of spending more time caring for patients. So the moment that a piece of tech does break down or malfunctions, then that is really impacting on that. So it's important that from our point of view, we go through all of those kind of checks and those product developments to ensure that that's the case.
Definitely. And there's two very brilliant points brought up there. I think the first that we'll jump in a little bit more with Richard for was, like you say, around sort of ensuring that all patients of various sort of backgrounds and understandings can make sure they can benefit from solutions we put in place. From your role with AHSN and the likes of the technology that you're very sort of forward when bringing into the NHS and very much championing, how do you manage sort of what is becoming a buzzword at the moment, very sadly, as we move to digital, which is managing the sort of digitally disadvantaged, and how we ensure that even those who don't necessarily have the same access can?
Yeah, it's a really important topic, Matt, and it's something which is both an opportunity and a challenge. I think digital exclusion is a topic which is increasingly on the priority list in recent years, and linked to our digital transformational services that we've seen over the same time period. It's I think for me the key word is co-production, and actually one of the risks we took, I think, perhaps knowingly and through necessity during those early months of the pandemic, was around the fact that actually the more top-down approach that was needed to accelerate some of the technologies that we rolled out prevented us from acting in a co-production method as we probably would do in a more normal times period within the NHS. So bringing back this concept of co-production, which is something we are particularly strong at the AHSN network, to understand from a population point of view, how we can properly embed technologies in a way that isn't going to create unintended health inequalities, for example, I think is a really important aspect for us. And as I said earlier, as you mentioned, the blended approach, I think, it has to be the sophisticated conversation. And it's not just specific to health. I mean, I've got a leadership role in education, and we've seen, fortunately, the kids are almost all back. But we've seen over the last 10 months, haven't we, that the lack of a laptop, the lack of an iPad is instantaneously an inequality when it comes to the ability of a school child to continue their lessons and their learning. So the same is true absolutely within the NHS. I think the one point I'd make is that it's also, I think, really important not to assume who the disadvantaged or the alienated groups would be. I think particularly when it comes to long-term health conditions, there are many expert patients managing their chronic conditions, above the age of 60, 70, 80 plus, who are absolutely adept at technology. And we've got some fantastic case studies of, I know a particular 96-year-old who's living in Nottingham who's absolutely using her smartphone to do a urine analysis, 3 times a week on this particular app that we're helping to support. So some fantastic opportunities there. Likewise, of course, due to either socioeconomic or other reasons, there'll be people who you wouldn't expect to be disenfranchised from certain remote or digital technologies who might be. So it has to be about co-production. It has to be about not making assumptions about who these groups are. And it absolutely has to be about that blended approach, because we also don't want to go at the pace of the slowest. And what I mean by that, of course, is that I think it's really important that for those who can use technologies, that in a certain way, give them satisfaction, give them high quality outcomes, but keep them out of the really expensive, really prioritized, face-to-face clinical time. It frees up the time for those clinicians to then be working with those people with more complex conditions. So for me, that blended approach is a really interesting debate to have.
Absolutely. And I suppose one of the other elements touched on there at the end is that often a lot of this time needs to be spent for complex patients. And very often what we find with these sort of complex patients is they may have specialists that they see among different organisations, different trusts. And I suppose that factors into, Greg, and we'll go back to you for this, what you mentioned with systems Brother puts in place where they will be able to operate among different technical systems, because as an NHS, we're an amazing organisation, but we sometimes forget we are actually lots of very little organisations all interconnected, and they may have very different softwares. So being able to make sure that information can travel seamlessly between them has to be a key consideration, doesn't it?
Yeah, I mean, that is a massive consideration, and that will undoubtedly hamper a lot of the advancement because of that, the bidirectional communication between these technologies, and that needs to happen. So you can get into a spiral, and we in our own organization have come across this, where you're almost buying software platforms to talk to the other software platforms so that the other one can talk. Before you know it, you've got a whole host of software platforms that are chunking together. So that is a really important point, and something that needs to be taken into consideration, and it will need. It's going to be hard to get all of those decisions made from all of those different bodies to get to maybe one solution where all of that can happen and all that communication can happen across those different platforms.
Yeah, absolutely. And there's also the consideration among that with all these different platforms, if they end up having to have solutions to talk to solutions, that takes time for staff to learn them and be able to understand that. And you mentioned, Richard, co-production. Co-production doesn't just have to happen with patients, it has to happen between staff as well. And that's probably a very big consideration. And I will say, as I ask this, we will probably also set live to the audience the next poll, just to warn you to vote in that. But as I was saying, Richard, co-production between staff is going to be a very key element into getting this efficiency as well, isn't it?
Oh, it's absolutely essential. We all make workarounds if the system isn't working in the way that we intend to. And if we've got incredibly pressurized jobs, we look at a GP, for example, they're working on a minute-by-minute basis to be as efficient as possible to see the patient in front of them. If you put something clunky that requires more than 2 clicks to access and then more than 2 minutes to complete, you're not going to get any kind of buy-in. And if there's a workaround, even if that requires them printing off reams of paper, that's what they'll do. And who can blame them for doing that? So we have to think about the fact that the staff are the end arbitrators of what works or not. And I think for me, if you're designing something without staff, then you're designing something that's never going to be used in the NHS.
Yeah, definitely. It is very much that sort of point, isn't it? That ultimately, as we've said several times on today's event, it comes down to delivering the best care for the patient. And the way that happens, staff will find a way. And if that means printing off lots of pieces of paper, they will do that, because it's the right solution, because ultimately they care about their patients. And it fits in quite nicely with what we're seeing from the poll, which was to question who in the healthcare system should be most concerned with embedding the best processes and systems for that. And we offered our audience a lot of different roles, from senior leadership down to end staff users. And there's a lovely mix there, which in my mind certainly seems to suggest that everyone has shared ownership of this. And I guess first we'll go to yourself, Richard, as somebody who is at that senior leadership and works with their colleagues on it. Is that something that's true in your organisation? I'm not going to get your names.
Absolutely is. I want to spare a little bit of thought for the poor IT departments who are kind of coming up on the rear there. They'd probably want me to say that actually it goes back to Greg's point about interoperability. When we're putting these solutions in place, they need to fit with the strategic whole of whatever, NHS provider, whatever type of form of NHS organisation it is. And so I'm sure they want to say that no matter how boring the IG and the governance needs to be, seems to be, and I think we've seen some great examples of some real frontline clinicians doing some, I built it last night type of apps, just because the pandemic necessitated a certain type of immediate solution. But the IT department would want to say that's all very well and good, but we do have there's a reason why we exist. Innovation is everyone's business. I mean, I think it sounds like a cliche to say it, isn't it? But it absolutely is. One of the things that I'm very passionate about is that we don't really have a good track record of putting innovation into everyone's job description within the NHS. So it can often feel like something that's done down a corridor somewhere by other people. Innovation therefore becomes something that's done to people rather than something that everyone has an empowered and evolved ability to either create or perhaps most importantly to adopt. So it has to be everyone's business. We have to think about it much more clearly in terms of our induction, but also actually going back further in terms of our education, making sure that we are growing staff or future staff who see innovation as their day job rather than the thing you do every wet Tuesday afternoon if you've got time.
Yeah, absolutely. And I suppose as well to you, Greg, is that something that from Bro's point of view, and just as somebody who is very much on the other side of that innovation conversation, to engage with lots of different levels, is that something that you've found in your organization as a benefit when engaging with sort of health or partners, I guess?
Yeah, I think when you're looking at any kind of process or automation, whatever it might be, being embedded into an organization, it's a responsibility of everybody, the users, the people making the decision, the people paying for it, whoever, everyone involved in that process needs to be involved in the implementation, the selection, you can't, even when you're looking at a solution, it can't just be, you have to start at the end point, people who are using it, people who are receiving it, and it needs to be the responsibility of everyone. But I really like Richard's point about, the innovation being everyone's responsibility, or everyone's, involved with it, everyone involved with it.
Yeah, absolutely. And a lot of sort of the conversations we've had up until this point have been, while they've touched on, they've sort of talked more generally, but one of the biggest impacts on technology, on innovation, has undoubtedly in the last 12 months been the pandemic. It's changed how our health services operated, and it has had so many negative situations, and we can never take away from that. We should never try and sort of lighten those situations. We should learn from them. But it has also given us an opportunity to look at ways that have perhaps been ingrained for years and years and do them better. And I suppose, well, first to yourself, Greg, from what Brother have seen, has that been from those that have reached out in the period of the last 12 months, has that been some of the sentiment they've shared, that actually a lot of their solutions, these problems haven't necessarily occurred because of the pandemic, but this circumstance has made them look at the problem anew and potentially spark this new conversation?
I think because of our particular solutions, our actual traditional business has really slowed down with NHS, and quite rightly so, because they've been focused on key projects that need to be delivered to ease the pressure during this the pandemic. So, prescription printing or printing in general within the healthcare sector has slowed somewhat. What we have found is, as a direct result, is that we've been able to supply and support the places like the vaccination centres, and we have obviously seen really quick kind of turnaround and decisions being made to support that, which is great to see that happens. So the Nightingale hospitals, vaccination centres, we've been involved in supplying solutions around those situations. But I think, some of the other advancements, that would be something that maybe hopefully down the line we get an opportunity as they get developed, and as the ones that are required after we're through the other side, hopefully that would be opportunities for us to get involved in those conversations and see how we can fit in and improve those workflows in those kind of solutions moving forward.
Yeah, absolutely. And I suppose that to yourself, Richard, is something that hopefully we've had the last 12 months have perhaps been reactive. Hopefully the next 12 months can be very much more proactive. From the technological sort of standpoint, COVID has obviously changed a lot of different bits and pieces, but have you seen there's been a lot of sort of different conversations maybe you've had more recently compared to maybe what 2 years ago would have been around technology, maybe with the HSN or with people the HSN are working with?
Yeah, no, absolutely. I mean, it's with the people the HSN are working with. I mean, I would say that, as an academic health science network, this role, the opportunity for technology to transform the way that we deliver health and care is something that is our day job. So, hopefully we get the job card and always have, even pre-pandemic. But the conversations that we're having, particularly with senior leaders, I mentioned earlier, we traditionally in the NHS, if we want to go further faster, it's about growing the workforce, finding more people, working harder, working longer. I think we are starting to recognize that the workforce is at a stage where that can't happen anymore. So leaders are starting to say, well, how else can we do this? And when you look at the challenge of the backlog that we're now turning our attention to, we know that there has to be a different way. I think what's great is that people have recognized that you don't have to be a technologist to have a conversation about technology.
Yeah.
In the same way that you don't have to be a finance director to have a conversation about finance. You just have to know the questions that need to be asked. And the key question is, how can we do this differently? And who's not in the room, who should be in the room to help us on their way. I think the partnerships that we've seen, particularly with the life sciences industry of the vaccination, the fact that AstraZeneca, Pfizer, others are now kind of household names where perhaps they weren't previously, are starting to show that the NHS by itself actually isn't able often to solve its own problems.
Yeah.
We've always relied on our fantastic partnerships. So that's the bit that I think we need to retain. We need to recognize that actually industry is a really positive addition to the toolkit of how the NHS does its day job. And leadership now starting to look at our relationships, our strategic relationships with industry as partners who can help our challengers, rather than that kind of previous, more commercial, transactional understanding of why people are knocking on your door.
And as you mentioned there, conversations, they're the bread and butter to how we get this innovation. And obviously, similarly, we'll extend that on to our audience here today, that if you do have questions for Richard or Greg, by all means, use our live Q&A functionality, ask us these questions, and we can very much put them to it. On that front, we actually had a question in before. We talked about co-production and that sort of benefit, Richard, asking about whether that also included co-design. Obviously, co-production, typically the technology having been proposed, but I suppose, as we said, it was very much covering both bases, wasn't it?
No, absolutely, it really was. And when you look at some of the work that we do as the HSN, I mean, so yesterday, for instance, we launched our new cohort of what we call the NHS Innovation Accelerator. That's a program which over the next 12 months will support a number of innovators and their emerging ideas to hopefully accelerate them into spread and adoption within the NHS. But within that would be an enormous amount of co-design. Really early conversations with NHS clinicians and others to enable that thinking to be plugged in at the earliest stage of development. There is no point getting to the end of your design timeframe and then turning to the NHS to say, do you have an appropriate shaped hole for this thing that I've built? Co-design has to be as early as possible. And particularly, of course, it has to be inspired by and rooted in the needs of the system.
Yeah, absolutely. And I suppose that's very much a conversation that Greg Brother probably have quite early on in a lot of the more innovative solutions that you provide, that having early conversations to understand what the need is, because ultimately we want to provide a solution that fits that need.
Yeah, absolutely. You can't get to the end of a project and then find out that, it's solving this problem and not the actual, the start goal that you're set off on. So yeah, absolutely. Everyone needs to be involved in the conversation as early as possible.
Yeah. And as we sort of continue down on this theme, we'll invite our audience to take part in the third of our live polls, asking around. And it's very much going back to a conversation that we had recently, but fits into this, that was around how we determine what the best solutions are. Obviously, we touched on the digitally disadvantaged, we touched on making sure solutions fit right, but how we actually decide what is the best solution for people. Is it case by case, or is it made by clinicians? So as our audience dutifully answers that in the background, I guess I'll go back across to yourself, Richard. With a lot of the conversations that COVID have changed, I imagine it's been quite a, perhaps not frantic, because frantic gives the wrong impression, but there's been probably a lot more conversations needing to happen about how to address need, because that need probably is changing and is a lot more dynamic than perhaps is normal in the NHS, because obviously circumstances are changing each week, it seems.
Yeah, no, absolutely. Some very COVID specific interventions that we've seen and supported over the last 6 to 9 months. And, you know, the phrase standing up is a new one for, you know, NHS dictionary geeks like myself. All of a sudden we're standing up a service over here, or we're standing up a service over there. But thinking particularly about a lot of the at-home work that we've delivered as the HSN network in partnership with NHSX in particular. But the virtual wards at home, which have allowed people to step down out of beds, hospital beds, with COVID symptoms in a much more timely manner than otherwise would be the case, as well as other types of at-home services which have allowed people to be monitored without having to take them into hospital in the first place. Those are services that didn't exist, at Christmas, and by January there was an active deployment, and by the end of the month they were pretty much in universal access, throughout the country. These kind of timeframes are unprecedented. I think for me, the interesting thing is to look at that not just as a kind of a standing up a crisis service, but thinking we have just managed to build and implement an at-home product using remote diagnostics and other types of previously available technologies, which are keeping people out of hospital beds. How can we now translate that into some of our more elective surgery or other types of clinical needs that we know, again, and coming back to this backlog, we are going to have a huge pressure on beds as we start to seek to reduce that hump. How can we use the at-home methodology to translate and transform the way that we consider people's rehabilitation, for example?
Yeah, and there were conversations in getting this speedy delivery of services, these standing up of these new services, but also in the migration to new ways of keeping these innovations in, that we're going to have the likes of Greg and the likes of Brother, where we learn how we can take what has been already an incredible turnaround, an incredible tool, and then tweak it further so that it works. And I suppose, Greg, from your side, that's, I'm guessing, something that the likes of Brother and your colleagues and yourself are very keen to be a part of.
Yeah, as I said before, I think a lot of these solutions, it will become apparent which ones need to be utilized post pandemic, and then it's, we want to get involved with the conversations as early as possible where relevant. Again, it goes back to that point right at the start. We don't want to be getting in the way of anything that doesn't need either that input or output at either end of the solution from us. We will get involved where we can see that we can add a real value and add benefits to that workflow, whatever that might be. So yeah, I think it'll be interesting to see how much changes post pandemic and what advancements there are, and that do get adopted long term.
Yeah,
hopefully it makes that decision making. It does have a positive effect on that decision making, and a more kind of flight of foot in terms of being able to react to situations and make decisions quicker, and it doesn't go back into maybe a longer death by committee kind of decision process.
Certainly, and as we sort of go to answer very much that point across to Richard and focus on the results of the poll, I will say to our audience, we are sort of we don't want to keep Greg and Richard forever. They are very busy individuals. We're very grateful for them to be there. So if you do have questions for them, by all means do send them in now, and we'll make sure that we still have time to ask them. But very much as Greg mentioned there, Richard, we want to make sure that the innovations we have stay around. We don't want to drift back. And it's interesting to me when we ask the question to our audience, who determines the best solutions for patients, what we should use, it very much is on a sort of condition basis, or it's on a treatment or a case-by-case basis. Now, currently, while we have the momentum, that very much will probably be looking forward, but it is essential, isn't it, that we don't drift back into what we know, I suppose. Once times go back to normal, or we have stresses over the backlog to get in patients, we have to make sure that innovation and what we've learned is still on our mind, isn't it?
Yeah, no, we absolutely do, Matt. I mean, one of the things that I think is worth saying, it's obvious, but it's still worth saying, is that not everything we've done has worked. Yeah. I think when you're putting things in at such pace, you have to be aware that although maybe the best intentions were there, the implementation of a particular pathway or technology just doesn't work for patients, or it doesn't work for clinicians. And actually what that means is that the rapid evaluation of technology and of the digitization of care pathways, for instance, is something that, again, the service, I think, has learned to appreciate and to do far more readily at a systemic level than perhaps we were doing 12 months previously. So that's, I think, the first thing to say, is that we need, when we're thinking about, do we kind of ping back to the way things were on a piece of elastic, or do we continue our journey? We need to be humble enough to say that there will always be times when we understand that things haven't been as good as they should have been in terms of some of the changes that were made. Because otherwise, I think you run the risk of both staff and patients being fearful of a deterioration in the quality of the service that the NHS gives. So we need to have that, I think, in the front of our minds at all times. And then, having said that, we need to absolutely ask ourselves the question, but what has categorically, on an evidence basis, worked in terms of the transformations that we've seen, and how do you then lock in those benefits? That's the crucial thing for us as the NHS. I mentioned about individual clinical workarounds previously. We do that on an organizational basis. We have the ability to not decommission the old ways of working, which then gives people a choice about whether they are looking at the new way of doing something or the old way of doing something. So we have to be, I think, be a bit more alive to the fact that unless we decommission old ways of doing things, people will have a preference, and people will express that preference.
Yeah.
But, and I suppose this is my own. This isn't with any kind of formal kind of hat on. I genuinely believe that although it won't be felt as much in the media or by our population at large, the crisis of the backlog is as significant as the crisis of the pandemic in terms of how it will be felt by the NHS. So in terms of the opportunity that brings, in terms of not allowing us to revert back to old ways of being, at least inside the NHS, we will continue, I think, with the same kind of huge, hairy challenges over the next 12 months, and therefore have no choice but to keep that conversation going about how do we do this differently? What's the technological answer here that could help us to reduce the reliance on our exhausted workforce? So I don't think as much will be written about it. And certainly I think for people outside the NHS, they won't feel it in the way that they felt the pandemic. But I think it will still feel very similar within the NHS in terms of the crisis mode that we're in and the kind of decisions we therefore have to make, and perhaps ultimately helping us to be a bit braver about the way we choose to go about things.
Yeah, certainly, and sort of keeping a little bit on that strand as well. One of the considerations that we do have to have is that although our clinical staff have largely worked brilliantly on the front lines, they've been still in. There's been a lot of sort of either maybe primary care staff or those who are in support roles who've also worked from home or worked remotely for a long period of time, and they're all going to have to transition back. We had an incredible turnaround in getting all this technology out to ensure they could do that. We've got to find the right way of also bringing them back, I suppose. And that is going to be quite a consideration alongside the treatment backlog, isn't it?
Yeah, no, it absolutely is. And first of all, we've got to ask the question of who needs to come back and why.
Yeah.
As you move into integrated care systems in particular, I'm sitting here in Sheffield today, but I'm actually sitting in the South Yorkshire and Bassetlaw integrated care system, with 2.2 million patients within it. We'll start to see some silos broken down in terms of organisational boundaries, and therefore, I think we'll start to see a lot of our NHS staff seeing themselves as employed by the wider system rather than this or that particular NHS trust or NHS commissioning organisation, which means you can very quickly start to think about working from home for those who can as a possibility for the future.
Yeah.
And if we can start to disconnect people from the need to travel, we start to really help our 2050 environmental goals. But equally, if we start to think about people as being flexible to work in different healthcare systems, then I think there's a lot that we've learned from remote working, which we'd want to sustain in the future.
Yeah, absolutely. As you say, it's going back to that wonderful thing that we have in the NHS, that although we are lots of different organisations, we're never really in competition with one another. We ultimately are all this one big organisation. And in lieu of sort of audience questions that need asked, I think we'll sort of, because I'm conscious we don't want to keep you for too long. You're both very busy people who have very important roles to get back to. It has been amazing talking to you. It's been an amazing sort of conversation. We've had such a broad and such a detailed discussion about all of the aspects of technology in healthcare. And so from myself, and I'm sure from the audience as well, I know I'd like to extend my thanks first to yourself, Richard, and to Greg, and sort of I'll go to each of you individually, but I'll offer you maybe a chance to either sum up or have sort of a final parting say to leave our audience, just to make sure they still think. So to Richard first, yourself.
Yeah, thanks, Matt, and thanks for this. It's been really interesting to chat to you and to Greg. I think the point I'd say is that I really think that if you look at the longer lens of history, 2020 could be an inflection point for the NHS. We've always talked about being maybe anchored to our 1948 model of working, and a lot of the transformation we've tried to do has been, I suppose, with that anchor maybe slightly resisting our abilities to really transform the service. My view is that the lessons we've learned from the pandemic, the technology advances that we've seen in such a short space of time, will ultimately be seen as the starting point of a really interesting journey as we transform the NHS from that concept of bricks and mortar to that concept of staff and patients and the public looking at health, not healthcare. So I think for historians out there, this is the time to start planning the book, because in 10 years' time, 20 years' time, I think looking back at this year will be a really interesting thing to do.
Certainly. And obviously to yourself, Greg, as well, we mentioned looking to the future, but I suspect very much that's brother's eyes. And again, thank you so much for being on today.
Thanks, Matt. Thank you. And yeah, just echoing the same thoughts as Richard there. There's going to be changes that are embedded in many organisations across not just NHS, but our own organisation, and looking at the way that how do we take the positives of what has been a really tremendously difficult year for everybody. No one escapes it. No one's escaped this year unscathed. So it will be really interesting to see how all organisations adopt new ways of working, whether that's hybrid working, which is something that a lot of organisations are doing. And I'm sure that's similar to what Richard was describing there of what might happen post-pandemic. So yeah, thanks for having me. It's been a really interesting chat. It's great to catch up with you guys, and yeah, thank you.
Amazing. And as sort of it's a given, it is very much all we have today, but the conversations will continue to go on in our own organisations and more collectively. I'm sure both Greg and Richard, as amazing panellists as they've been today, any follow-up questions people have, I'm sure they'll be happy to answer. And similarly from ourselves and from my point of view and National Health Executives, will continue to deliver news events like these and bring together sort of solutions and ways of looking at problems that potentially we haven't before. So thank you to our brilliant audience today. Everyone stay safe, and I hope everyone has a lovely afternoon.
Thanks very much.